Hello, I'm Dr. Richard Heuser. Um, I'm talking on the 1 year update on Verve's non-vascular renal denervation device for uncontrolled hypertension. I'm the founder, I'm a co-founder of a company called Verve. The founder and the CTO is Terry Buena. I am also a major stockholder in Verve. When you talk about any technology, it's all about needs. It's why technology is developed. 30% of patients worldwide have hypertension, 1.4 billion worldwide. And unfortunately, 86% don't have their hypertension under control. That's more of a problem in the United States than around the world. This is the cover of our textbook coming out next month on renal denervation. This is our second edition. First edition we wrote and was published about 10 years ago, right after the results of the Medtronic renal denervation device in the New England Journal of Medicine, showing that actually compared to a sham control, it really didn't work. One of the things was in common with all of the devices when we wrote this first edition of the textbook, there were about 50 renal denervation devices. All of them were consistent. They treated the nerves that parallel the renal arteries, and they also had based all of their work on animal studies, not human studies. Excuse me. So the problems with the arterial approach to treat hypertension, only 60% of hypertensive patients are anatomically eligible for renal denervation in the renal artery. Small percentage of the nerves parallel the renal arteries. 30% of patients with hypertension are non-responders to the arterial approach for renal denervation. And you don't know if the patient is a responder from 1 month to 12 months following the procedure. And renal insufficiency is a relative contraindication to renal denervation by the vascular approach, with the fact that over 100 cc's of contrast is going to be utilized for renal denervation and the vascular approach. The patients also need to be on antiplatelet agents and heparin with treatment. At the time of our first textbook edition, a very devastating article came out, not only the New England Journal article, but this was a case report of a patient treated in the Netherlands with the Medtronic renal artery approach towards denervation. This was a 38-year-old lady with severe hypertension, 230 over 140, who had the renal denervation performed, and there was no change in her blood pressure. And about a month after the procedure, she died of an aortic dissection. So this is the first and only case of the arterial approach where they found histopathology. And in fact, as we know from our first couple of weeks of medical school and training to be a medical doctor, everybody with hypertension has got thickness of the wall of the artery. So this is the wall of the artery. This is where the probe was present. And even though the probe delivered energy, radio frequency energy, about 2 millimeters, it didn't hit the renal nerves. And in fact, the renal nerves are seen to not have been damaged or ablated. In fact, this is what goes on in the renal denervation. Let's remember, the most severe pain somebody can have is from a kidney stone. And that's because in the renal pelvis where the urine is collected, it's dilated, and there's a plethora of nerves there. And this is the majority of the afferent nerves supplying to the kidney. So the afferent nerves, as you remember, go from the organ to the brain. And in this case, they affect blood pressure. So we took a different approach towards renal denervation. We were a urologic-based company. And so we decided, working with experts in urology, that the best way to assess our device was to do a procedure in patients who are going to have their kidneys removed anyway. So there was Dr. Desai outside of Mumbai, India, had patients that were coming in from all over the world with kidney disease. This is a typical diseased kidney. So what we do with our device, we treated the patients with our device, and then the patients had pre-planned uh, nephrectomy a month later. So the Verve device is a 75 centimeter long catheter with two helical diameter sizes, small and standard. The RF generator is monopolar, delivers low power energy, less than 30 watts, for about 2 minutes with a temperature of 60 degrees centigrade. Now, you cannot apply RF energy unless you are in contact to the surface. So if we don't get contact to the renal pelvis, we just pull back the catheter, extract the urine, and we get contact. Here's our probe with 4 electrodes where we apply RF energy about 60 degrees centigrade. So this is a magnified view. Again, this isn't a patient, this is a human a month after they had the renal denervation. The arrows show the area. There's vascularization of the nerves. And in fact, if we look at front and personal, this is a non-area, an area that was not treated. Here's the renal pelvic space. And you see these white lines, which are the nerves, and the parallel the arteries here. If we look at this slide, we see that all we need to do, because the pelvic wall is so thin, it's only 1.75 millimeters, all we need to do is get down about a millimeter in order to ablate the nerves. And this is what it looks like after ablation. You don't have to be a histopathologist to see we've hit all the nerves and they're all ablated. Now, when we got started doing the procedure, we went back and did some animals to see if we could go in with a ureteroscope and image as we go ahead and deliver energy or RF energy. So this is a picture of this done in a pig in China. So let's go ahead and play this. So as you see the yellow, there we go. So there's a red, beefy tissue, and as we ablate, it turns very pale. And you see the scream from the background, excited about the fact we've ablated. So again, all we have to do is get a millimeter down. So we're the only company that actually has described renal denervation pathophysiology in a human clinical nephrectomy model. We did this on about a dozen patients. So what about in patients who have hypertension who present? Well, this is a paper that we wrote with our 2-month data treated in Asia, in this case in Georgia. Dagmar Ahern was the first author. Senior author was Michael Weber, both experts in hypertension. And in this case, we performed this proof of principle feasibility trial. So we took this on 20 patients, and they were maintained with ambulatory 24-hour monitoring, daytime, nighttime, and maintained. And we followed the patients at 2 months, 6 months, and at 12-month intervals. So we took 41 patients with hypertension. Some dropped out because of COVID. Remember the time, this is a couple of years ago. Some patients did not qualify in terms of inadequate blood pressure. 20 patients with hypertension were treated. We did 2 off-med subjects who we didn't really follow. We took the patients on med, 18 patients. One of those 18 patients was lost to follow-up. The age, 56, female subjects, 39%. GFR was normal. The average hypertensive drugs just under 3 at 2.7, and the usual sort of antihypertensive drugs. The RF energy was delivered, again, through the urethra, through the natural orifice, into the renal pelvis, and we applied energy in the renal pelvis. It's an open label, single arm feasibility trial in patients with uncontrolled hypertension on antihypertensive drugs. So 18 patients were treated, completed at 12 months, 17. Average age, 56. Number of blood pressure drugs, again, 2.7. History of coronary disease. Many of the patients had some coronary disease, prior stroke. GFR was normal in these patients. These were patients with normal renal function. So we published this in Hypertension last fall. We found therapeutically significant blood pressure reduction in 100% of treated patients. The Verve's modality reduced mean 24-hour systolic blood pressure by 20.3 millimeters of mercury, and using this SPRINT method described in terms of treating blood pressure 22 millimeters at the 2-month primary endpoint. Well, what about 12-year follow-up, 12-month follow-up, sorry. Again, senior author on this was Michael Wepper. And then I was listed also as a co-author with Dagmar Herring, who was my fellow working with me as a Fulbright scholar, was second. So if we look at the chart, blue is pre-systolic, green is post-systolic, same on diastolic. All the patients dropped their blood pressure, and this was a significant drop. Corresponding diastolic drop was also significant and decreased over time. The blood pressure achieved significance at P equals 0.001. If we look at this graphically, systolic and diastolic again, all the way starting from day 1 out to month 5, there was a continued drop in blood pressure. This shows us graphically from month baseline 2, 6, and 12 months. So if we put it all together, systolic blood pressure dropped just under 20 millimeters of mercury with a significance of 0.001. Diastolic dropped just under 10 millimeters of mercury with a significance of 0.001 also. So from our 12-month observation, there was a reduction of baseline of 148 millimeters of mercury with a 24-hour systolic blood pressure drop by 19.3. Diastolic pressures also fell. Automated office blood pressure was reduced from 156 by 16.8 millimeters of mercury, again, significant at 12 months. All blood pressure changes at 12 months were no different from what we saw at 2 months, confirming the durability of the procedure. Serum creatinine also fell from 1.03 to 0.82, and the GFR rose from 79.6 to 96.3. This was never and has never been seen in the arterial approach, where the GFR actually increased and the creatinine decreased. Again, these were patients with normal kidney function. There were no serious procedure, clinical, or laboratory adverse events related to the intervention. This is what we see graphically in terms of blood tests, cholesterol, et cetera, GFR. So no serious adverse events. Mild transitory back pain following the procedure. Now, these procedures are done by urologists. When urologists apply radiofrequency energy for nerve ablation, for pain relief, et cetera, or working on removing stones, they normally will leave a stent that can be extracted non-invasively. In other words, it can be pulled out a week later. So they did this. And in the patients that had these stents placed, they would have some mild transitory pain that went away after the stents were removed. Serum creatinine decreased by 0.08, and GFR again increased in all patients at 12-month follow-up, and this was significant. So our conclusions that these findings provide evidence that these significant blood pressure lowering effects of renal pelvic denervation seem to be durable and safe for at least 1 year, and again form the basis for the pivotal randomized blinded sham controlled trial to further define the safety and effectiveness of this procedure. This is great that this works in 12 months in a small number of patients, but we need to do a sham controlled trial to show its effectiveness. The study could not have been possible without the group at the Georgian Medical Research Telescore in Tbilisi, Georgia, and also wouldn't have been possible without Professor Wepper and Professor Dagmar Herring, again, my Fulbright scholar at the University of Gdansk. So let's summarize. Our approach is not reliant on renal artery anatomy. We don't require an arterial puncture. We ablate both afferent and efferent nerves. The afferent denervation appears to be more effective. Minimal treatment time, about 20 minutes. We see an early response time. There's no systemic contrast. There's contrast in the collecting system, but this is not systemically absorbed by the patient. The arterial approach requires a patent renal artery and invasive arterial puncture. Again, only about half the patients are candidates because of our other vascular issues. Ablates predominantly efferent nerves, requires fluoroscopy, prolonged systemic contrast, and there's a risk of thrombus as well as stenosis in the artery due to vascular site access and treatment energy. Treatment time is greater than 45 minutes. Renal denervation appears to be safe. And again, as I mentioned, a well-powered sham control trial is needed to fully establish safety and efficacy of the renal pelvic denervation in patients with uncontrolled hypertension despite medication therapy. So we have received approval from the FDA to initiate the Novel Denervation Pivotal Investigational Device Exemption, IDE, of the company's minimally invasive non-vascular transurethral Verve medical renal pelvic denervation system for uncontrolled hypertension. And we've named the study the NOVEL trial, natural orifice via pelvic denervation. So 6 differentiating features I want to reiterate from the vascular approach. There's no vascular exclusions, no systemic contrast utilized, no use of aspirin, heparin, or Plavix. There's an immediate blood pressure drop within 24 hours, and all patients are responders. If we put in a ureteroscope, we can see the immediate success of ablation if we want to do that. But we see that with the blood pressure drop, and there's an improvement in renal function at 12 months. If one has any questions about this technology or wants to learn more about Verve's non-vascular renal denervation, please contact me. My website is richardheuser.com, and my email is heuser58@gmail.com. Thank you very much.